Hi, my name is Kate Hanneman. I'm a cardiac radiologist from Toronto General Hospital and an associate professor at the University of Toronto. Along with Dr. Ravzin and Dr. Gasharja, I spoke in a session focused on cardiovascular complications related to COVID-19 illness and following COVID-19 vaccination at RSNA 2021. My talk specifically focused on the cardiovascular complications and cardiovascular imaging following myocarditis related to COVID-19 vaccination, and highlighted a recent review article that I wrote on this topic along with one of my recent fellows and several colleagues published in Radiology Cardiothoracic Imaging late last year. Soon after COVID-19 vaccines began to be administered widely, there were emerging but rare reports of adverse events, including thrombosis with thrombocytopenia syndrome following administration of the viral vector vaccines, as well as myocarditis and pericarditis following administration of mRNA-based vaccines. We've learned quite a bit more about this in the months since, and it is clear that some individuals are at slightly increased risk of myocarditis above baseline after administration of mRNA-based vaccines, but the overall risk is very low. And myocarditis has mostly been described following mRNA-based vaccines in young men, including both adolescents and young males, and rates are approximately 10 times lower in female peers. The estimated number of extra cases of myocarditis following administration of mRNA-based vaccines in males aged 12 to 29 years is 41 cases per million second doses above baseline, compared to about 4 extra cases per million second doses in females in the same age range. The risk in young children between 5 to 11 years of age appears to be much lower, and the risk of myocarditis is also quite a bit lower in adults who are more than 30 years of age. So this sex difference between males and women, and specifically the predilection for adolescent and young adult men, raised the possibility very early on that there may be a role for sex hormones and specifically testosterone in the pathogenesis of mRNA-based myocarditis following administration of mRNA-based vaccines. The risk is also higher after the second dose compared to the first, and has also been described in patients who have a prior history of COVID after administration of the first dose, suggesting that prior exposure is relevant. We know that cardiac imaging plays a very important role in evaluating suspected myocarditis, no matter what the cause is, and this is most importantly using cardiac MRI. When we're evaluating cardiac MRI in cases of suspected myocarditis, we would most commonly apply the revised Lake-Lewis criteria, looking for both a T1-based and a T2-based abnormality indicating myocardial injury and damage, as well as myocardial edema, respectively. Based on the data that's been published to date, it appears that the imaging pattern of abnormalities on MRI in patients with myocarditis after vaccination is similar, if not indistinguishable, from abnormalities in patients with myocarditis due to other causes. However, there is some data to suggest that the extent and the severity of abnormalities on imaging in myocarditis following vaccination may be milder or less severe compared to myocarditis due to other causes. This is reassuring, but we need ongoing study to understand the potential long-term risk and outcomes in patients with myocarditis after vaccination. Limited clinical follow-up data to date suggests that patients who have myocarditis after vaccination tend to have a fairly mild disease course, often recover quickly with complete resolution of their symptoms within a few days. However, we don't have robust imaging follow-up data, which will be important to understand whether patients are at risk of long-term adverse events, including arrhythmias, that could be related to residual scarring or fibrosis in the heart. We do know, however, that the risk of myocarditis is much lower following mRNA-based vaccination compared to the risk of myocarditis following SARS-CoV-2 infection, which can also result in myocardial injury and inflammation in the heart. This is a really important consideration when evaluating the risks and benefits of vaccination to prevent COVID and to minimize severe outcomes, including hospitalization. Further study is needed to characterize the risk of myocarditis following subsequent doses, including boosters, and to evaluate longitudinal changes on imaging at follow-up. Thank you so much.